those little teeth fall out and the permanent teeth come. And they often come a little bit skewed, sometimes a little bit more skewed, like this one. But now what happens is we have growth of the tongue. And the tongues are very small at this age. But the tongue grows, and as the tongue grows, and it pushes against these irregularities here, it can expand this area. And if we do extractions, look at what happens. This little girl had extractions done in the lower. Only the lower canines were taken out. And these teeth fell into the space of the canines. And what did they do when they fell into the space? They tipped backward. What did the upper teeth, which teeth came first? These ones. These ones followed. These teeth tipped backward, and these teeth were looking, oh, where's that other guy for me to meet? And they tip in because the lips are pushing against it, and they're pushing against it, and they're tipping back those upper incisors. Can you see her TMJ issue? She has massively locked in deep bite situation. She's impinging on that joint vertically, massively, because of this stupid serial extraction. I don't mind crowded teeth. I would prefer to have a bit of crowding in the teeth than have this kind of situation develop. Look at what this little kid did. He was sitting there playing with his tongue against that little new tooth. Look at that beautiful little new tooth. And so I was seeing him do this because he was doing suction. His brother was getting brackets and he was doing the suction tubes. And I was seeing him playing with the tooth, and I said, Louis, can I take a picture can I take a movie of you doing that with your tooth? Yeah, sure. I'm going to be an orthodontist one day. And I said, I'm going to take your pictures to Taiwan. And he says, oh, where else are you going? Is my movie gone to some new places? That's what he asked me. Actually, Louis is big now. He has all his permanent teeth, and this is long, long time ago, and he has no extractions or serial extractions or anything done. Isn't it beautiful how that tongue is always against that little rough surface of that tooth, pressing against it like no orthodontic appliance can do? Beautiful. Don't put something in, let the tongue do its work. And not have this kind of thing develop. Okay, so we finish this off. We have space issues. That's the premolar. This is the second primary molar. We have crowding in the front. But what do we also have? We have that. And what I see in orthodontics is not that tooth. I want you to imagine that tooth is still under cover. Okay? And what do we measure? This. And I would prefer us to measure that. And not decide arch width according to what we see here, but rather to decide arch width according to where canine tips are going to come through. Because I can do a hell of a lot with these teeth here. And ideally, we can have that develop into that. Let's look at this little case here. No space for canines, premolars or baby teeth here. And typically, like Curtis said this morning, Curtis Westerson said this morning, V-shaped arch. Now look at this. Isn't this amazing? That tooth is coming there. It's doing that all by itself. There, look at that. I didn't need to tell it to go there. It does it all by itself. And it does that over and over and over again. They always come more buccal than palatal. Did you know that? They always come more buccal than palatal. We just need to help them and keep, with the buccal shield, keep the lips and the cheeks away, and they will do that beautifully, because they can. Yeah, as they can. This is where we started. And this is where she ends. She does not have bimax protrusion. Those teeth are upright. It's all about giving that arch shape a U shape instead of a V shape. And this is what we see on patients that have extractions done. This is the side with no extractions, and I'm going to flip this over onto this side here. And look there. She's only missing. She hasn't gained anything by doing extractions. And it's stupid they did a canine extraction on her. Now this lady here, she had an early premolar extraction done. So the canine slipped into that. The midline slipped over. Everything slipped into the canine extraction. And then she lost a permanent molar here when she was 20. Now look at this. I'm on the central suture. I'm on the outline of these teeth. I'm going to flip this. Now I don't even dare to push it on the central suture. Look how much incongruency there is from left to right. This mandible is being shifted massively into the left-hand joint. Can you see that? And this is what really happens. If we do extractions in the maxilla, we have a full cortical plate here, and this is all cortical bone here. Cortical, dentoalveolar cortical plates, okay? Now, if we take out a tooth, that is what invariably will happen. And this is not something that I invented. You will see where I get this from. And the mandible, does the mandible get smaller when I do extractions? No, we have a cortical ridge here. We have a cortical ridge here. And this is like a horseshoe. This stays the same size. It does not reduce in size. So now I have a small upper arch, a lower arch that has teeth that are all tipping inward, but it's still a large bone, fitting into a smaller upper bone. And where does that go? Backward, upward. And this is where I get this from. If we have extractions on the upper teeth, if we lose teeth on the upper, we always lose bone from buccal to palatal. Can you see that? Reduction from outside to inside. What do old people look like? A lot of mandible, very little maxilla. Are you with me? How is it that we orthodontists think that if we take out teeth that we can prevent this from happening? I don't believe it. If we take out teeth, we will do that sort of thing. Only in a small way, but we will do that. In the mandible, if we lose teeth, this is on a larger scale, we lose vertical height. But this is not of importance for orthodontics because we have enough teeth supporting vertical. So watch this. Taking out a tooth here, taking out a tooth here, and losing maxillary supportive tissue will drive the mandible, especially with lower lingually inclined teeth, will drive the mandible backward into the joint. And I have a lot of kids coming into my office with this sort of thing. Here, adult patient, look, as he opens his mouth, he shifts over to the left. Did you see that? I'll go back. Look at the midline shift, the crossbite, extraction here too. Look, as he opens, he goes into a corrected midline. This is the ski jumper. Can you see the ski jumper? That's his centric relation. His bite has absolutely no value. His bite is only where his teeth mash together to be able to chew. That's all the information we can get out of that. It has no value as far as skeletal references and condylar position are concerned. That's where his splint is. And you can see we're leveling out. That's his occlusion. And now in his splint position, he's centered out. Crossbite. And here you can see that crossbite there. He does not have a crossbite on this side, but this is the side that is pushing the mandible over onto the crossbite side. And there his splint is correcting that and correcting that. Okay, I think we will go into break.